First of all, thank you very much for the invitation. Thank you very much for the opportunity to come out here. I want to state from the very beginning that I would like to make this less of a keynote and more of an interactive process. I'll be here with the panelists throughout the day, but as I'm going through my information, I won't even call it a presentation. When I go through my information, if you have any questions or would like to just stop and discuss things, please feel free to. We are extremely ahead of schedule, and I find that when I attend workshops or conferences like this and have an opportunity to see a speaker, a lot of times there's information that really doesn't pertain to me or it's not relevant, and I wish I would have been able to raise my hand and ask a related question. So I'm here to tell you that I would much rather tell you things that you're interested in hearing and try to answer questions that are relevant to what we do at St. Luke's than to fill you full of a bunch of useless information that has no bearing on what you're doing. So that said, please stop at any time. You don't even have to raise your hand, just ask a question. I'm much more comfortable making this a dialogue than I am standing up here spouting St. Luke's stuff. Anyway, so I put this little presentation together, and I decided to call it Creating a New Paradigm for Hospital Food Service. I know we have several healthcare, hospital, food service people in the audience, and I'm glad because I would like you guys to help and join in and share your ideas too at the same time. So let's see if we can move through this. So these are just a couple of random pictures. We are, and my next slide I'll talk a little bit about. I want to give you an idea of kind of where we are geographically. Very similar to Butte, Montana, from a climate standpoint, not so much from an arid standpoint, but we suffer the same type of agricultural limitations as Butte and Montana in general. We do have a lot of local farms, and we do, obviously, we do a lot of business with our local farmers. So, from a geographic standpoint, this is Minnesota. These are the Twin Cities down here, so the capital of St. Paul. This is Lake Superior right here, and Duluth is right on the shores of Lake Superior. The city of Duluth has been compared to San Francisco in the sense of the hilliness. We literally come right off the lake and climb 800 to 1,000 feet. So in the wintertime, when we have 3 to 4 to 5 feet of snow on the road, getting home can be an extreme challenge because you're climbing straight up these hills. And again, from a farming standpoint, from access to agriculture, we are challenged. We have a very limited growing season. So let's talk just briefly about St. Luke's. We are an independent hospital. We are not part of a larger healthcare system. We have one hospital. We're licensed for about 250 beds. Our average daily census is about 170 patients. We have 2,500 employees, roughly. We do have off-site clinics that are primary care clinics, specialty clinics, urgent care clinics, and those clinics feed the hospital as far as from driving patients to an inpatient status. We represent, from a geographic standpoint, 17 counties, 3 states. So we have the upper peninsula of Michigan, we have northern Wisconsin, and we have most of northeast Minnesota in our tertiary care range. The hospital was built in 1881. We were the first hospital in Duluth. Duluth is a population of about 85,000 people. And just down the street from us, we have our main competitor. They are the Essentia Health System. It's a Catholic-based health system. They have about a 500-bed hospital. So we are the smaller hospital in the city, in the region. And we'll talk a little bit about that later, in that my belief is that because we are the smaller number 2 hospital, it gives us a tremendous amount of flexibility, and we have, from an organizational standpoint, a lot less layers than they do. So when we want to make changes and we want to do things when it comes to our food or anything in our support services area, we're pretty nimble. From a medical standpoint, I'm sure it's much the same as any hospital. So I thought what we would talk about today from a hospital standpoint is what is our role in food service? What is our role in healthcare within food service? And what we've been trying to do over the last 7 to 10 years. Talk about what our local responsibility is and the decisions that we make or that we have made on a daily basis, on a short-term basis, and what we're looking at long range and long term. So, to give you an idea of how I ended up getting called to come out here, because when Carl called, I said, "How did you get my name?" And who? Yeah. I don't. I want to be clear that I don't want to take any credit and claim to be any type of national authority on anything. And when it comes to the changes that we made and the things that we do, it is completely driven internal. We have no outside pressure, and all the changes and the improvements and the directions that we've taken is all from within, primarily from within the food service department. We don't do it so I get to travel around the country speaking. Which, by the way, this is like the second time I've done this because I have a hard time kind of bragging about what we do. So I was invited to speak down in Minneapolis. I was actually just part of a panel, and that's how Carl was put in touch with me. And really I was invited to kind of talk about the same things, which is how does a hospital make changes that can affect the local economy, whether it's through farming or even local producers with respect to doing business with local bakers or doing business with dairy farms. It's not always just about produce. But the history of how we got started, and I should say that my title is Director of Hospitality Services. I started there as the food service director, and then like everything in life, my boss said, "Man, you're doing such a great job, we'd like you to be in charge of our laundry too." So we have an on-premise laundry that we have these big gigantic machines, and so we do all the laundry for our hospital, all of our clinics, and we have contracts. So I took the responsibility of 3 million pounds of laundry every year and about 25 employees. And then a couple of years after that, my boss said, "Man, you're doing such a really great job. We want you to be in charge of environmental services." And that is the trend in healthcare right now, is one person wearing many hats. So that's how hospitality came to be born. My background, my life, my passion has always been about food. And even though myself and my 3 managers have the responsibility of 160 employees, and we have the housekeepers and the janitors and the cleaning attendants and the laundry workers and the porters that move the laundry all over the place, most of really what we focus on every day is food. And that's just a selfish thing because we were all food service managers before we became hospitality managers. So a long time ago, a local farmer approached us and literally just walked in the door and said, "I have organic spinach. Would you ever be interested in buying it?" And I said, "Sure, of course." And that's how this whole thing started. And again, just a little bit more background. Like Carl said, I grew up in California, and when I graduated from college, I didn't know what I wanted to do, but I had always worked in the restaurant business. So this is early 80s, mid 80s. I enrolled in culinary school. At that time, there were 3 or 4 culinary schools in the country, and so consequently, living in San Francisco for 3 years, living in Sonoma for 7 years after that, it was very common for me to have farmers knocking at the back door of the restaurant saying, "I've got 3 bushels of vine-ripened Roma tomatoes. Do you guys want them?" Or wild mushrooms, or whatever the case would be. That was very common in small owner-operated restaurants to have farmers just knock at your back door. That developed into building relationships with these farmers, which is something that we were really proud at the restaurant that I was working at, to the point where we would meet with the farmers that we had been doing business with during the growing season, which in California is pretty much year-round. But we would meet with them, and we would build these relationships so that I could dictate what they were going to grow. So if I wanted a certain kind of radish or a certain kind of tomato or a certain kind of green, we could start planning ahead, and they knew that that was something that I would be interested in purchasing. But from the farmer's perspective, I think it gave them a sense of security, knowing that if they grew it, we would buy it. So we started developing these relationships with local farmers back in the mid-'80s, really, after I finished culinary school. And it was wonderful, because we were supporting a local economy. I was able to help steer the farmer into, don't grow that because we won't buy it, we don't like it, no one wants to eat that. And the best part was we were working together and having them grow things that we knew that we were gonna use. So when the farmer knocked down the door at the hospital, this is probably back in 2003, he just had some fresh, locally grown organic spinach. And we bought it. And it wasn't a big deal, but we put it out on our salad bar in the cafeteria, and we just put a little 3x5 card that said, fresh, locally grown organic spinach. We have about 1,800 people that go through the cafeteria every day. Staff, docs, visitors, volunteers. And it was crazy, the emails and the phone calls I got, just praising us for putting local spinach out on the salad bar. And it was really like, not a big deal. There was no foresight to it at all. It was an opportunity, we took advantage of it. And that's how things started to snowball. And when people in our community discovered that we were starting to sell locally grown products, the phone calls started coming. Hey, I understand you guys are selling locally grown stuff. Would you be interested in this? And so we started forming all these relationships. Some of them have continued since 2003, and some of them come and go. I had a guy, a farmer in north central Wisconsin, call me probably 2 or 3 years ago, and he had 800 pounds of potatoes. Would you like them? I said, absolutely. But we're not going to take 800 pounds at once. We'll take 200 pounds over the 4 installments, because we can't sit on 800 pounds of potatoes. And I've never heard from that guy since, and maybe he'll call me again sometime. So some of these relationships that we've built with local farmers have continued, and some have just gone away. I have had relationships with farmers where we will sit down and make a commitment to buying their product, and only to find out later that they have backed out. I was dealing with a farmer who only grew lettuce, and we committed to buying, I can't remember what the amount was, but we committed to buying a significant amount of lettuce from her. And when it came down to fulfilling her commitment, she couldn't do it because her farm was basically herself and her husband, and they realized after they made this commitment that they didn't have the labor to produce the amount that we wanted. And that happens, and that's okay. From a hospital food service standpoint, when we're working with local producers and local farmers, if they can't come through, I just pick up the phone and call U.S. Food or call Cisco or call Food Service America. I mean, there's always a supply, but our goal is to always try to use as much of our local product as we can. So when farmers are unable to commit or unable to fulfill, we're okay. We don't have to close the cafeteria or say to the patient, sorry, there's no food today. Another, I think, milestone that we had was we wanted to serve milk without growth hormones, and at the time we were purchasing all of our liquid dairy through our broadline vendor, which is U.S. Food Service, and we approached them and said, hey, we don't want to buy milk unless it is free of the growth hormone, the BGH growth hormone. So they went to their dairy supplier, and their dairy supplier basically said, we have that product, but we don't have the ability to bottle in the small cartons like we use in healthcare for our patients and for our cafeteria customers. And they went so far as bringing the rep from the dairy company, and this is Land O'Lakes, this is a huge dairy company in the Midwest. They brought him all the way up to Duluth, Minnesota, 180 miles north of the Twin Cities, to explain to me why they couldn't provide us BGH-free milk. And I said, that's great, I'm really glad you made this drive, but we want milk without hormones. So what we ended up doing was canceling our contract with for liquid dairy with US Foods, and we found a small cooperative in southern Minnesota. And they provided all of the dairy to us. And the point, I think, is that we as consumers drive a lot of what happens in the marketplace. And so consequently what happened, it took probably 8 months to a year for Land O'Lakes to finally convert a bottling line so that they could put their BGH-free milk into cartons. And so kind of putting some of that pressure back onto our suppliers was helpful in getting what we wanted. The other thing that we work with is a GPO. Is anybody familiar with what a GPO is, other than our food service people in here? A GPO stands for a group purchasing organization. And what a GPO does for a small, independent northern Minnesota hospital is give me the buying power of all the member hospitals in the GPO. And this GPO negotiates on our behalf, along with all the other members, national contracts. So whether it's chicken or yogurt or frozen pastries or whatever. And they give us the opportunity to purchase at a better price than if we were just a small independent hospital. It gives us like the strength of McDonald's. McDonald's probably doesn't ever have to worry about negotiating their price for Coca-Cola, because if Coca-Cola would ever lose McDonald's, I don't know what they would do. So it's similar to that. When it comes to sourcing local products, the GPO is no benefit to us whatsoever, because the GPO stretches across the entire United States. And the purpose of it is, if you're a hospital in Florida or you're a hospital in Oregon, they are sourcing contracts for products that you can get in either part of the country. So from a local sourcing standpoint, the GPO is worthless to us, because the GPO has nothing to do with local producers, local farmers. So we feel a lot of pressure from our GPO to buy on the contract. You have to buy on the contract. This is why we have a contract. And what we have done at St. Luke's, and I think a lot of other hospitals are following suit, is we have elected to buy off the contract. And so when we talk about the milk, we bought off contract for that milk. And of course, the first thing the GPO says is, well, you know, you're going to pay so much more money. And the truth of the matter and the reality is that the milk that we were buying from the co-op in southern Minnesota was the same price and even a couple of cents less per carton to us and to our patients and to our cafeteria customers than we were buying from the US. So from a healthcare standpoint, there is a lot of pressure on both sides. One, to be as local friendly as possible, but also to kind of march in step with the GPO and take advantage of those contracts that they're negotiating on our behalf. Yes?
Is the GPO pressure the same on public and private healthcare institutions?
Yeah. Yeah.
Uniform?
Yeah. There's really no really no differentiation between a public hospital or a privately held hospital. Yeah.
Are you getting legislative pressure from like gaps when you're purchasing local foods?
Not
you don't have to adhere to, like, you don't require any of your farmers to have GAP certification or anything?
No. A real quick similar story is, and I know very little about certification for organic farmers, but my understanding that is it can be an expensive process to become a certified organic farm or farmer. So we deal with a lot of farmers that approach us and say, we follow the organic farming standards, but it's just me and my wife, and we can't afford to become a certified organic farm. So we follow the protocol, but we're not certified. one of the things that we've always adhered to when it comes to purchasing food is we're not about buying all organic. We're not even about buying all local, but our philosophy has always kind of been to provide the healthiest alternative to our patients, our staff, that we can possibly do. So sometimes buying local is not necessarily healthier than if we would buy from somewhere out of state. Please ask questions. Yes?
So, in terms of processing, do you work with some people to process, or who processes all this food? Is it the hospital that does it, or is it directly come from the farmers, or is it, is it mainly fresh food and vegetables that only get put out, or?
Well, when we're talking produce, vegetables, fruit, it's a combination. Some farmers that we work with have facilities to wash and get it to us in a clean stage. Some farmers don't. And again, kind of backing up, the healthcare industry has gone through, the hospital side of healthcare, has gone through some real financial challenges. Our Medicare reimbursement is continually cut year after year after year. We're the only industry, I think, that I know of that, if you come in and you have a total hip and we bill your insurance company $40,000, we're the only industry where the insurance company comes back and says, all right, we'll give you $26,000, and that's all we're going to give you, and we take it. And the difference is what we call an allowance. And so if you look on our P&L statement at the end of every month, we have millions and millions of dollars in allowances because what we bill and what we collect are greatly different. So from a processing standpoint, from a labor standpoint, years ago, back in the 90s, we had in our kitchen, in our production area, we had a lot of people that did prep. I mean, when I got my first job in the kitchen, I was a prep cook. And it was scrubbing potatoes, it was cleaning lettuce, it was everything. Because back then, there was no further processing. Once it left the farm, it was boxed and it went to us. And so I remember cleaning just 3-compartment sinks just full of lettuce every single day. Now we don't clean lettuce anymore because that's the way it comes to us. When we deal with our local farmers, it's a balance. Some of our farmers have the ability to wash and get it to us as processed as possible, and others don't. And therein lies the challenge. So if a farmer comes with 800 pounds of potatoes and they're all full of dirt, we have to take that into consideration as far as, okay, how many do we want to buy and how much time do we have to be spending cleaning all these potatoes? Yes?
How are you working with your, we have a county sanitarian that I work with at my hospital. Have you ever had the issues with the sanitarian having issues with you purchasing food that is either A, pre-processed or comes in unprocessed and unwashed and then you have to deal with it?
I will have to admit, and it still blows me away, that no one since 1999 when I started at St. Luke's from the county health department has ever come into the hospital.
Really?
And again, my background and my history is working in restaurants, and you were always prepared for the county health inspector. And so anyway, our hospital is surveyed by the Joint Commission, which surveys all of the hospitals. And while I don't know this for a fact, my assumption is that the county health department says, we don't need to go inspect the hospital because the Joint Commission goes in there. And when the Joint Commission comes into the hospital, when they come to the kitchen, they're much more concerned with fire and what do we do in the event of fire. They're concerned with temperature logs and how we are maintaining appropriate temperatures. But there's never been a question on vendors. Now, I will say that all of the farmers that we work with will sell through the Duluth Farmers Market Cooperative. Years ago, we had a business model and a plan that we had hoped to implement where there are usually 20 to 25 farmers at the Duluth Farmers Market. And again, our farmers market is, you can blink and you'll miss it because it goes so quickly. But our hope and our plan had been to have one farmer in the middle and have all the farmers sell, in a sense, to that one farmer, and then we could just buy everything from one farmer, write one check, and then that farmer would kind of disperse. And there's one farmer at the Duluth market who is a little bit bigger and a little bit more well-established, and was ready to rise up to that challenge, but the farmers were never really keen on that, and I don't know why. So when I say we're buying from farmers, it's just not like some random person. These are people that have farms, that are businesses, that have license, that they themselves are being inspected. But I also always tell people that if someone comes to the back door and says, you know, I'm with Branovan Farms and we grow lettuce and spinach, and you know, we had a bumper crop of spinach and we're just trying to sell it and get rid of it, would you want to buy it? I'm much more comfortable doing that than opening the box of spinach from Chile or South America somewhere, and I have no idea where that has been or how that has traveled. So that's always kind of been my justification as far as, okay, I know this farmer, I know that they have a farm 6 miles away. Where this spinach from U.S. Foods came from, I mean, it says a product of South America. How do I know? So thank you, good question. So we obviously can't do this alone, and that's part of what the whole day is, really. It's about kind of partnering with our community farmers and producers. We don't just buy local produce. We buy local bison. We buy, from a local standpoint, we have 3 local bakeries, 2 of which are organic, and we buy from them. So when we talk about buying local, their flour may not be local and their sugar may not be local, but to me, to St. Luke's, they are producing locally and we are helping to support local businesses. So it might not be local products that we're buying, but it's being produced locally and we're supporting our local economy. So when we talk local, it's really about support too. So I don't know, I guess you can sort of kind of read this, it's kind of small, but food composting. I was having dinner last night with Camille and with Zoe, and we were talking a lot about Butte and Montana, and I was, I guess, really surprised to learn that there's not a whole lot of composting going on. We were one of the first facilities in Duluth, probably the first, to start a composting program that was off-site. So we have a sanitary district. They're an independent quasi-government organization, and they're the ones that turn all the water into drinking water. They also serve as the transfer station for solid waste. So all the trash trucks come, they dump all their solid waste onto a floor, and they scoop it up, and then they take it to the landfill. They had somebody probably very similar to Camille that said we should start a regional local composting program here. And so they approached some of the large-scale food producers, and they asked if we would be interested, and we absolutely said yes. So shortly thereafter, probably in 2007 or 8, composting became mandatory for large-scale food producers. So all the bigger restaurants, all the grocery stores, the hospitals, the universities in town, we all compost. We started just composting food prep waste, and now we compost everything. So when food comes down from the patient floors, it goes right into the compost bucket, out of the cafeteria, and then obviously still all the food prep waste that gets composted.
I know of some hospitals that when they started using local foods, their food waste went down considerably.
Yeah.
Do you have any data on that?
I don't have any data, and I don't know that I would feel confident saying that our food waste went down, because we're still buying. The reality is that because of where we live geographically, our local farmers can never satisfy the demand that I have, let alone the bigger hospital down the street, the University of Minnesota, the College of St. Scholastica, the DEC. We have the Duluth Entertainment, which is where the hockey teams play, and the symphony's there, and they do a ton of food. So the amount of food that we get from our local producers is still just a fraction of what we're using. So I don't think our food waste went down.
Well, I guess what I mean, well, in the Netherlands there's been quite a bit of research done that if they use local foods and really present it in an appetizing way, the amount of food that goes back to the kitchen after they eat
Oh, I see.
goes way down because people are just more excited to eat it.
I would agree. I don't know that we've really seen any statistical data that would prove that. As an aside, and we can talk a little bit about it later, we recently, a year and a half ago, transitioned our patient food delivery system from a traditional tray line into a room service style, where patients pick up the phone, call, and within 45 minutes their meal is delivered. We have seen a significant reduction in food waste there. Tremendous. Not just from the fact that in the tray line days, if it's Friday at 10 o'clock, we say, here's your menu for Saturday. Tell us what you want for breakfast, lunch, and dinner Saturday. I mean, I'm a healthy, have a decent appetite right now. I can't tell you what time I'm going to be hungry on Saturday, let alone how I'm going to be feeling if I'm a patient, let alone if I'm going to be hungry. So from a tray line standpoint, a lot of these trays were going up. You know, you're ordering 10 o'clock on Friday for a dinner meal on Saturday, and a lot of these patients were like, I'm not hungry. So food was being wasted just at unreal amounts. And now if you go into the dish room, when the trays are coming back from the patient floors, you can lift up the domes, and it's amazing. Prior to tray line, we estimated that 85% of our patients ate less than 50% of their food. Since we went to room service, 75% of our patients eat more than 80% of their food. It's just incredible. Because the window of time that you're ordering your food and getting your food is so minute compared to the way it was. We also do food rescue. We talked a little bit about this yesterday. We have a food bank in Duluth. It's a regional food bank. The food bank supplies food to the food shelves and the emergency feeding programs in our region, in our community. So if we have food that's left over that is not ready for the compost, but we're not going to serve it again because of whatever reason, that food is all packaged, it's labeled, it's dated, it's identified, and it's frozen. And the food rescue truck comes by the hospital 3 times a week. It's a refrigerated truck. It's staffed by ServSafe certified employees. These are people who have gone through ServSafe training. And they come by us, they come by the grocery stores, the other hospitals, the universities. They pick up food in the morning, and in the afternoon they drive around to all the emergency feeding shelters in town, and they give the food away for free. In the old days, I would have a feeding shelter call me and say, we just don't have any food for tonight. Do you have anything you can donate? And that would be the day that we ran out of everything. And then 2 days later, we'd have leftover lasagna, and they'd say, no, we're good. So the food rescue and the food bank fills that niche and kind of established that hub for us. We talked recycling. I mean, we recycle everything that we possibly can. With local food initiatives, we've been talking a little bit about that all day. We're starting a food hub in the Lake Superior area, and the whole purpose of the food hub is very similar to what the food bank is doing with rescuing, is that it's making a central hub so that I don't have to call 6 different farmers to see what they have, or that one farmer doesn't have to call 6 different hospitals to see if they can sell 600 pounds of potatoes. Right now it's very small. There's about 4 or 5 growers, and there's about 4 or 5 consumers, myself, the other hospital, and the 2 universities in town. And it's very, very new, it's very, very small, and it's just starting. And our hope is that it will become a local food hub, and there will be someone in the middle that is facilitating, so that when a farmer calls the hub and says, hey, I have all this to bring to market, I can call the hub and say, what's coming on the market today? So almost on a daily basis, I know what's coming to market. So I don't have to waste my time calling 10 different farmers.
I have a question about that. How
Yes.
important do you think that is to, like, other institutions purchasing that might not be as willing to have as many accounts open as it sounds like you are with this farms that have a 2-person operation?
It's very important, and that, again, that gets back to why we were trying to establish this this business with the Duluth Farmers Market, where we only had to write 1 check. The food hub it will suffer the same problem. So if our accounting department says, look, you've got way too many vendors, we want you to consolidate. I mean, that's what a broadline food service distributor wants you to do. They want you to buy everything from them. It is a challenge. It's not for me. It hasn't been. I haven't had any repercussions saying, you know, don't, you've got too many vendors. But for others, it may. The problem stems with when you're working in a large organization like a hospital. What I've heard is for every check that needs to be written to pay a vendor, it's like $75. By the time the invoice comes in and it gets coded by that person, then it goes into the AP journal, and as it makes its way through to where the check finally is cut, it could take $75 worth of resources to cut a $25 check for produce. So we talked about the farmers market. Sustainable Twin Ports, it's a program that we went through. It is basically helping organizations learn to be more sustainable. It was a little bit premature for us to go through it, but we went through just as a food service, not as an entire hospital, and it has some phenomenal potential, but it really needs to be at an organizational level, not just at a departmental level. We partner with the University of Minnesota. Some folks at the University of Minnesota were given a grant to do a GO study. They came into our cafeteria and they did a 6-month manipulation of products in the cafeteria. So they did things like they manipulated prices on healthy food and not healthy food secretly. In other words, one day the price of French fries just kind of went up and no one really said anything. And they studied all the data from purchasing habits over the course of 6 months. They changed and manipulated labeling. They manipulated educational materials. They did a stoplight program where bad foods were red, and I say bad, but they had criteria on what made it bad, whether it was caloric or sodium. Red, yellow, and green, and then they studied purchasing habits and all that, and that study's been published, and you can find that online. And then, of course, Healthcare Without Harm has always been a big partner of hospitals like us. I'm just going to fly through. So we talked a lot about our local farmers and farmers markets, dealing directly with a hub. We've recently established what's called the Good Food Network, and here's just a little blurb on what it is. Basically, it's a regional collaboration coordinated by Anti-Hunger, Community Garden, Farming, University, and St. Luke's Rep, working to build a healthy, green, fair, and affordable food system. It is really, the way I describe it is anybody and everybody that has anything to do with food in our community needs to be part of the Good Food Hub, or the Good Food Network. And that's just what it is. It's not an organization, it's not a nonprofit. There's no building, there's no offices, it's just a good food network that tries to keep people in touch with the goal of providing good food in our region. And I'm just kind of flying because I'm realizing we're getting close. And I don't think I have too many more slides. From the healthcare standpoint, one of the biggest challenges that we all face, and I get phone calls all the time, how did you convince your administrators to let you do this or do that? I'm very fortunate that the vice president that I report to, we have a very good relationship. I present my ideas sometimes after the ideas have been implemented. We do a lot of work to engage our customers. We find we find physician champions, that's huge. We have a lot of physicians that are employed by the hospital, and we have a lot of independents, so it's always good to have some of those physicians as your buddies. Physicians carry a tremendous amount of weight in the healthcare system. Money, money, money. So another question I get all the time is, man, isn't it so much more expensive to buy local and buy organic? And it can be. And with us, the proportion of local and organic and all those things that we buy is still around 20%. So we can see price fluctuations in some of those products, but stuff that we buy from U.S. food goes up in price too. It's not just local. And we have this flexibility to stop. So at one point we were buying organic bananas, and they were the same price as regular bananas, And so we just, we have a nice little basket with fresh bananas out in the cafeteria, and we just right on top of the word bananas, we just wrote organic. And wow, people just went crazy, organic bananas. And then pretty soon the price to us started going up, and we had a choice. We could either pass that cost along to the consumer, or we could just choose to not carry those bananas. When the price doubled over the course of probably a couple months, we just scratched out the word organic and we went back to bananas. And again, I spoke earlier about being a relatively small hospital. We're pretty flexible in the ability to do things like that. But that's a question that I'm always asked, is kind of the money side of it. Some of the things that we've done to make us maybe stand out, I don't know. Again, it's tough for me to brag, but we eliminated bottled water, and it just, one day it was just kind of struck me that it was silly that we have bottles of Dasani water when we have, Duluth has some of the best drinking water in the United States. And so one day we just stopped ordering it, and we went out and bought reusable bottles, and we sold them to our cafeteria customers for the exact same price that we paid. And when people said, hey, you can't stop selling bottled water, we would say, here, just buy this bottle for $4, which is basically 3 bottles of Dasani. And I promise you it will last more than 3 bottles, and you can fill it up anywhere, and so we got rid of bottled water. We eliminated our deep fat fryers. Again, one day, one of the fryers broke, and we just decided not to fix it. And what we did was, in the meantime, we went out and researched products, and we found that there are products out there that you can oven bake instead of deep fat fry, and so we just decided to get rid of the fryers. Again, there was no plan. The fryer broke. We didn't fix it. The next thing you know, hey, St. Luke's eliminated their deep fat fryers. It's in the paper, and everyone's talking about it, and it was just not a big deal for us at all. We have tried desperately I would say to not good success, to increase the healthy selections in our vending. We're open from 7 a.m. to 7 p.m. in the cafeteria, and so we have obviously folks that work all night long, and they need access to good healthy food as well. But healthy vending just isn't, it's just not happening. People still like Reese's peanut butter cups and Lay's potato chips and that kind of stuff. We had a rooftop garden, and I would love to tell you that we had it again this year, but we just don't have anybody that can go up there every day and take care of it. But it was very primitive. We bought some kiddie swimming pools. You know, they're about 6-8 feet and about 2 feet deep, and we fill them up full of soil, and we grew lettuce, and we grew spinach and kale, and we had tomato plants up there, and peppers and herbs, and all of that came down and was used in the cafeteria. I would love to say that we didn't buy anything else from U.S. Food because we had so much in our garden, but it was really like a tiny little fraction of what we were using. And again, the last one on here is don't ask for permission. A lot of the stuff that we do, it just happens, and then we have to kind of explain ourselves, and most of the time it sticks. There you go, don't ask for permission. So we've talked about room service, we've talked about GPO and our broadline vendors. We talked a little bit about how we transitioned into room service. The only reason we did that was to satisfy our patients, and our patient satisfaction scores have gone through the roof. It's crazy. But food is about the only thing when you're a patient that you have to look forward to. Everybody else coming in your room is poking and prodding and bothering you, and food is one of the only things that folks look forward to. We've just made other changes along the way. We have eliminated all the styrofoam. We've gone to compostable, recyclable paper where we can. We buy reusable to-go containers. We have a program where employees purchase them, a one-time purchase, and they do it on a trade-in basis. We give them a little token. They trade it in. We give them the token, and then when they come back through the cafeteria, they take a brand new clean to-go container, and we collect their token, and they're not charged for it, so that's been a huge success. And then I think the last thing on here is sugar-sweetened beverages. And I'll talk briefly about sugar-sweetened beverages. So we have been trying to eliminate sugar-sweetened beverages, and I am extremely proud to say that on September 17th, our administrative team made a decision to eliminate all sugar-sweetened beverages from our organization. We're the first hospital in Minnesota to do it, and there was an article that came out in the local paper, I think it was Monday or Tuesday, which was perfect because Wednesday I was on a plane for Butte, Montana. So I will say that there has been an overwhelming vote of confidence from folks calling and talking with me. There are a few people that are upset that we've done it. But I think the primary reason people are upset is they feel like we're taking away their choice, and we're not. We're just not selling it. So you can bring a Coke or a Mountain Dew from home, and you can drink it while you work or drink it at your desk, or you can do whatever. You can bring a 12-pack in and have a little cooler in your office if you want. We're not saying that. We're just choosing not to sell it. And so, so anyway, that was really, really huge. I know it really doesn't have a whole lot to do with farming and local produce, but I've always felt that as a healthcare organization, we have a greater responsibility to provide healthier food for our patients, and sometimes that means taking some things away. And sugar sweetened beverages is huge, and there are plenty of organizations across the country that have already done it, and there will be plenty more that will follow suit. So I don't have anything else. My contact information is right there. I am always willing to talk to people about what we've done and help them any way I can. So any other questions? Yes.
Who writes your menus?
We do, meaning food service department. And we are also kind of atypical in that our clinical nutrition staff reports up to the nursing chain of command while we report up the support services chain. So there's collaboration. I don't supervise the dietitians. They go up through nursing. And but we have a tremendous amount of collaboration. And one of the things that I think we succeeded on was we had, from a therapeutic diet standpoint, I bet we had 15 or 17 different therapeutic diet menus during the tray line day. And as we were making this conversion into room service, it was our opportunity to really hone down. So what we did was we tried to make our regular diet low sodium, low carb, all those low diets that we had, so that if you were on a 3 gram or if you were on a low carb, you could still have our regular menu, and all of our menu items have carb counts next to them. And we use that menu as a teaching and an educational tool, especially with diabetic patients. Our call center, the people that answer the phone, through the computer system, they have the ability to see what diet they're on and what they can and cannot or should and should not be having. And they are trained and scripted to help negotiate with the patient rather than saying, nope, you can't have that. But it's more of a, hey, instead of having the chocolate cake, how about we send you some fresh fruit or something like that. So.
Okay. So then do you or your 3 managers, do you guys write the menus and have to do the nutrient analysis and everything on is it a cycle menu that you guys are on?
For room service? For the patients?
For the patients.
No, it's
yeah.
one menu.
Oh, it's one menu.
It is one menu. It's like going to a restaurant.
Okay.
So you've got breakfast and it's served all day, and then you've got sandwiches and salads and soups and stir fries, and we have wild Alaskan salmon, we have a strip steak, we have bison, and that's the same menu every day.
Okay. So does JACO require you to have the nutrient analysis?
Yes, and we do, and that's the clinical nutrition.
Okay,
so when we were
amazing.
building the menu, every menu item and selection had to have a nutrient analysis done.
Okay.
And we use a program called Computrition,
Mm-hmm.
and our house-wide computer system is Meditech, and Meditech will tell us what diet the patient is on that the physician has ordered. That pushes down into Computrition, and once Computrition sees that you're on a 3 gram diet, it opens up and we can see everything that you can and cannot have. And we do negotiate with patients, and we do have the ability to say, you really shouldn't have that, but based on what you ordered for breakfast, we can allow you to have that for lunch. But just know that when dinner time comes, you're going to be a lot more restricted based on what you've already had.
Okay. So, sorry to harp on this.
That's okay.
I have a lot of questions because I'd love to go this direction in our hospital. Do your dietary aides have like a handheld Palm Pilot kind of thing so when they go into the patient's room, it'll list the patient and then their diet order and then give their
Yeah,
options on that?
some carry laptops, some carry iPads.
Okay.
Um,
Ooh, iPads.
most of our patients, we have a really spoiled IT department. You know, they just love toys, and so we get toys too. Most of our patients are able to pick up the phone and call themselves. So they're looking at a menu, and they can go down. And of course, in the call center, the people that are receiving that phone call from the patient, they have computrition up on their screen, and they know exactly what's going on.
Thank you.
You're welcome. Okay, I've successfully, yes, ma'am.
How do people respond when they ask for a chocolate cake and you say, how about a fruit platter?
Well, it's all about perspective and negotiation too. We have some patients where we will post a dietitian to that patient, and I don't want to say we just cave and say, all right, you can have it. But if the dietitian that's working with that patient says it's okay, a lot of times we will make those exceptions. And what I learned very on in my healthcare food service career from a wonderful chief clinical dietitian was, on an average, a patient is with us for, 2 or 3 days maybe. When they go home, guess what? They're going to eat the entire chocolate cake, not just the piece that we didn't serve them. So we think about that in perspective. I was up visiting a patient just 2 or 3 weeks ago, and I can't remember, he got turkey sausage, and he must have been on a pretty restrictive diet, and he was just a grouchy old man. I want to see the director, and so I went up there, and he told me that he didn't like this turkey stuff, and he wanted real man sausage. And if we sent this turkey sausage to him again, he would throw it out the window. But again, I have the luxury of just saying, you need to talk to your physician, because we have to do what your physician tells us to do. We don't have the choice. So.
To a certain extent, I look at it as an educational learning opportunity for patients.
Absolutely.
And that's one thing that we're looking at in our institutions is how can we make these healthy meals delicious, beautiful, things that you want to recreate at home.
Yeah.
As opposed to a sentence while you're with us.
Yeah.
We're trying to teach you a better way so that you can be healthier and hopefully not come back to us in the future.
And we encourage all of our patients to take the menu home because they are one-time use, and use it as a
teaching tool.
If nothing else, like, what should I have for dinner tonight? Oh, let me look it up. Let me look up the menu and see what I had when I was there. So.
Right.
And I'm sorry, I didn't bring any menus. That was kind of foolish of me, but.
So do you mostly not use local food for that set menu, or do you use your local food when you're managing your cafeteria?
No, in fact, if we have we have a St. Luke's salad on the menu that has mixed greens and salad, and if the mixed greens and spinach, I should say, if we have that in-house and it's locally grown, that's used. But again, the amount that we're purchasing is, we have a $1.3 million food budget, and so it's minuscule.
So is anything on the menu labeled local, or do patients know that they're getting local food if they're getting it?
The bison is raised locally.
Does that come through the process?
It does. And the sad thing is, again, talking about sourcing, we have a local bison farmer in Esco, Minnesota, which is, 15 minutes down the road. And he's a extremely old gentleman. He's the nicest, coolest guy in the world I've ever met. But we started buying bison from him, running it in the cafe, selling it to the retail side, and we ran him out of bison to the point where he said, I can't get you bison for 3 more years because I have to wait for these guys to grow up before we can. Yeah, so now, unfortunately, our bison is not coming local, but it's coming through U.S. food, but it's still a Minnesota product. Last week, we just met with a gentleman who owns a meat market, and he is on the verge of implementing a mobile slaughterhouse and processing. So we have a lot of farmers that produce beef, but they have to have it processed down at the USDA plant, which is like 225 miles away. And so their cost is just through the roof because they're paying for all of that. So this guy is designing a mobile slaughterhouse. So he'll be able to go out to that cattleman ranch, slaughter, and break it down into major pieces, and then bring it back to his butcher shop and further process it and get it to whatever we want. So as soon as that gets into effect, our local beef supply will be phenomenal. We'll be able to get more than we need, I would suspect. Sir?
One thing I noticed abroad was that the more hospitals started buying local food, the more the big companies like US Food Services would try to incorporate that offer in their own.
Absolutely.
Is that something you see happening?
Absolutely. In fact, US Food, to their credit, now when you go on the US Food website from a user standpoint, when we go in to place our order online, locally grown products or locally produced products or Minnesota companies are flagged. So it gives us the opportunity to say that we can try to support more local business. And again, a lot of the stuff, it's merely produced locally. It may not be, the original parts might not be all necessarily local, but it gives us a chance to support local businesses. Yes?
I was just wondering, do you have a problem with US Foods like holding a contract with them? I've as a producer, I've had that posed to me by restaurants that they have to actually, stick with their contract with their main purveyor.
Yeah.
And I was wondering if that's a problem with your local producers and US Foods.
It's only a problem It's only a problem for me if I make it a problem. And I'm just, there are other healthcare hospital organizations out there that are part of a bigger contract like Sodexo and Aramark, and those people are, those food service operators are probably much more regulated. But I have the luxury of being an independent hospital, and so again, getting back to that GPO, yeah, the GPO really wants me to buy everything I possibly can buy, not only the products that they have negotiated on my behalf, but using US Foods as my distributor. And so we see incentives, and we have incentives on the distributor side that say, the fewer drops per week you take, the more money we'll give you back. And the bigger your drop size, the more money we'll give you back. And the quicker and sooner and faster you pay your invoices, the more money we give you back. And what we say is, we weigh those and say, you know what, we would rather take our dairy to another co-op and lose what incentives we may be getting. So we have pressure, but it's a voluntary program. We have the ability to walk away. So if Bob's Food Distribution knocked on my door and said, hey, we want to come in and sell you everything you're buying from the U.S., I could say, sure, okay, great. But his pricing would have to be comparable, and his selection would have to be comparable, so, yeah.
I might be able maybe to add just a smidge to that, because I've heard that a lot also. I run the hospital kitchen as well. A, contracts are always negotiable, and B, I think that those food service distributors want to stay with a company or with a restaurant, so I think that is a little bit of a threat sometimes from these big food service distributors, but at the same time, they don't want to lose you. So
Right.
if you say, I'm sorry, you need to renegotiate, or I'm sorry, this is kind of the way I want to go, they typically will bend, or they'll look the other way, or they'll...
Absolutely.
Because they don't want to lose that contract, basically. So they are, it seems like, I think a lot of times you can, I don't want to say hide behind that, but I think that they are negotiable and you can work around.
So as a producer, how would you talk with someone that gives you that information? How would you
Usually
entice
beef, they
them?
don't really want it yet. They don't want it enough to want to talk, have that difficult conversation with their suppliers. That's usually, yeah.
A good excuse.
Yeah.
Well, and just real briefly, when we announced that we were removing sugar-sweetened beverages, the Coca-Cola rep was on the phone with her boss and the regional VP. But in reality, I will say that Coca-Cola and sugar-sweetened beverages compared to diet beverages, Diet Coke's our #1 seller, and it outsells our number 2, 3, and 4 combined when it comes to 20-ounce bottles. But yeah, it's you're in the driver's seat because you're the buyer, you're the consumer. And we found that with milk. As soon as we said, okay, fine, we just won't buy liquid dairy from US Foods anymore, they panicked because that was a huge chunk of our business. And they worked really, really hard, and it took them a couple months, and then they finally got it back.
I think we'll have more time for questions later, so let's go.